both here today. I can help moderate the chat for questions as you're talking. I imagine you want to kind of save questions and discussion till the end, but I can keep an eye out and let you know if there's any sort of clarifying things that come in that would be helpful to take a pause and address. But otherwise, I will turn the floor over to you both, and really am excited and grateful to have you here. You're muted, Katie, if you're talking.
All right. Do we have a thumbs up for screens?
Yeah, okay. Looks great.
Perfect. All right, awesome. So thank you so much for having us today. Stephen and I are delighted to be here. We're going to talk about, as Courtney said, how to choose implementation science frameworks and health equity, an overview for early stage investigators. And just to set expectations for today, our talk is geared more towards early career investigators who are newer to implementation science or investigators who are pivoting into implementation science. And so in terms of our agenda, we'll cover the role of theories, models, and frameworks in implementation science and the relationship to health equity. We'll talk about considerations for selecting a framework based on your research question. We'll have brief highlights of commonly used frameworks. We'll talk about EQUR, CFR 2.0, the Health Equity Implementation Framework, and the REAIM extension. And then we'll talk about implementation science in practice with an application to real-world research. So throughout the next 45 minutes or so, we'll move from conceptual to more applied. We really want to know what's on your mind and make this as helpful for you as possible. So please drop your reactions and questions in the chat. We'll aim to answer on the chat live and have more discussion at the end of the presentation today. So just to level set, since we have a broad group of folks here today, implementation science is defined as the study of methods to promote the adoption and integration of evidence-based practices and interventions into routine healthcare to improve population health. And so essentially, we want to find out how to get what works to the people who need it with greater speed, fidelity, efficiency, and quality. Without attention to equity, we absolutely cannot do this work well. And in the field, we're seeing an important focus on health equity, with inequities in implementation increasingly being recognized as an important factor in the unequal benefit of health interventions between groups of people who experience differing levels of advantage. So today, we'll look at how theories, models, and frameworks in implementation science can support our work to advance equitable implementation. And so the use of theories, models, frameworks, or TMF is foundational to our work as implementation scientists. Importantly, theoretical approaches help us understand and explain how and why implementation succeeds or fails. We want opportunities to identify factors that predict the likelihood of success and develop better strategies. Importantly, theories are explicit and open to examination and interrogation. Theories, models, frameworks provide structure for our design, our measurement, and our evaluation across studies. And they also create a shared language to facilitate building an integrated body of knowledge and interpreting it. So they give us a way to communicate with one another, which is so vital given how interdisciplinary our work is. You have two neuroscientists with you today. Implementation science is known for having many, many different theories, models, and frameworks, and it can be really difficult to determine where to even start with all of this. So I really like this helpful schema or tool from Nielsen's classic paper that can help us organize. And we'll be focusing more on frameworks today in contrast to theories. So in thinking about where do I start, a key question to ask yourself is, what do you want to use implementation science to accomplish? If you want to describe or guide the process of translating research into practice, then a process model might be right for you. Process models specify steps in the process of translating research into practice, including the implementation and use of research. So the aim is to describe and or actually guide translation. So there's a key temporal aspect here. One example to highlight is the PISCE model, which maps out 4 phases: exploration, preparation, implementation, and sustainment. and provides guidance on what to consider at each phase. If you're more interested in using implementation science to understand and or explain what influences implementation outcomes, then you might explore determinant frameworks. Determinant frameworks specify types of determinants which act as barriers and facilitators or enablers. And you might think about these as independent variables on implementation outcomes, which you might consider dependent variables, which are the primary outcome measures for implementation science and distinct from clinical outcomes. An example here is the consolidated framework for implementation research, which we'll talk more about in a few minutes. But you can use this framework to predict or explain barriers and facilitators to implementation effectiveness. Determinant frameworks can also be used to inform choices of implementation strategies that may best address contextual determinants. So actually mapping strategies to overcome specific barriers or leverage facilitators. You can also use them to generate hypotheses to prospectively guide predictions of implementation outcomes, or look back, retrospectively explain implementation outcomes by assessing differences in determinants across implementation settings. So thinking like, why did implementation go so differently across settings? Were there perhaps different barriers or facilitators within those settings? So next up, let's say you want to evaluate implementation. You're in evaluation framework territory. Evaluation frameworks specify aspects of implementation that could be evaluated to determine implementation success, so our implementation outcomes. A little bit more on these. These are focused on the extent, so how much, and the quality, how well of implementation. So in other words, the measures of how much and how well implementers do the thing. They then serve as the necessary preconditions for attaining subsequent desired changes in your clinical outcomes, which is really where we want to get to. Implementation outcomes thus serve as indicators of implementation success or failure. Because importantly, and continues to be the light bulb moment for me, an evidence-based intervention won't be effective if it's not implemented well. So as an example here, you can see Proctor's conceptual framework for implementation outcomes, which highlights our familiar outcomes like acceptability, feasibility, and fidelity. We can think about grounding our use of various frameworks in equity with some key considerations here. And importantly, the use of multi-level frameworks can ensure that reviewing inequities through a systems lens, really seeking to understand the relationships, the interactions, and the behaviors of the components that affect the systems. Process frameworks can help us ask, how do we implement equitably and engage key constituents in the process? Determinant frameworks can help us ask, where are the barriers, especially related to structural determinants? And evaluation frameworks can help us think about, did the intervention work? And importantly, for whom? So I'll pause here and just prime you with some questions to marinate on over the next half hour or so, and we'll circle back to these at the end. But if you might start to think about, in what ways might your research focus on understanding equitable implementation, reach, or adoption of an evidence-based intervention? What are the explicit and implicit assumptions that are baked into our frameworks? Why might you adapt an implementation framework to include a health equity lens versus adapt an existing health equity framework to implementation science? And we get asked this a lot. When might you consider combining different theories, models, or frameworks within your projects? So diving in, let's take a closer look at a few different conceptual frameworks together, and we can think about how they might apply to your equity-oriented work. So we're in the acronym territory of implementation science. We'll talk about EQUR, the updated CFR, the Health Equity Implementation Framework, and the REAIM extension. EQUR, the conceptual framework of equity-focused implementation research, is a process framework that aims to reduce or prevent the increase of existing inequalities or inequities during implementation. As some background, when EQUR was published back in 2019, so just a few years ago, The developers noted that few implementation research frameworks included explicit health equity considerations during the whole implementation process, and therefore couldn't necessarily determine whether the implementation could positively or negatively affect inequities in health. And if you look at the history of this framework, ECOR built out from Paula Braveman's 2003 conceptual framework for monitoring equity in healthcare, which proposes 8 different steps to follow, in which the last step was responsible for developing a strategic plan for implementation, monitoring, and research. ECOR's developers emphasize the importance of this last implementation step. And we often think about implementation as that last mile, that last step, which is so critical. Because importantly too, implementation research as an approach can help prevent new interventions from worsening inequities, or by actively work to diminish existing inequities or close gaps. So step 1 in ECOR's process cycle is to identify the health status of the population as the starting point in each cycle and as the focus of the health intervention. Step 2 is the equity-focused planning phase, and it's important here to identify the relevant research questions, taking into consideration the disadvantaged populations that are potentially impacted by that program that's being implemented, either positively or negatively impacted, and to quantify the inequities to be addressed, plus the possible equity-focused recommendations to be implemented with that program. In step 3, during the ECOR design phase, you can next identify key players, so healthcare professionals, patients, community stakeholders, other constituents, and identify barriers and facilitators for the implementation of those recommendations. During this phase, it's also key to consider equity-focused implementation outcomes in order to identify the best research design to evaluate the impact of implementing the program based on those outcomes. And you can see here, this actually pulls in Proctor's implementation outcomes, which we saw on our evaluation framework slide, which then allows you to measure the outcome differentially between advantaged and disadvantaged populations. And you can see here, this is an example of an evaluation framework being incorporated into a process framework. Step 4 for the ECOR implementation phase, you design strategies aimed at overcoming the barriers identified and define the monitoring and evaluation approaches. Step 5 is to evaluate and monitor those implementation outcomes that you selected. And in step 6, the equity-focused health population status is included as that final step and the new starting point for this or any other program or intervention designed to improve inequities. And this cycle is meant to be reiterated on for continued improvements. It's an ongoing process of research and evaluation. So transitioning over into the CFR, the Consolidated Framework for Implementation Research, or CFR, is a determinant framework that allows us and aims to identify contextual factors, which are those dynamic and active forces working for and against implementation efforts in the real world. Another way you might characterize or describe barriers and facilitators. The new CFR, based on end-user feedback, also sometimes called CFR 2.0, is an update of the original. It's been widely used across many different settings, from healthcare to public health to education to agriculture, for lots of different functions, including guiding data collection, data analysis, data interpretation, and designing implementation strategies. This new version here incorporates feedback from experienced CFR users to inform updates to the framework. The CFR 2.0 is intended to be used to collect data from individuals or people who have power and/or influence over implementation outcomes. The implementation determinants are organized across 5 key domains. The first being innovation characteristics. And then you can see individuals involved, inner setting, outer setting, and then off to the right, you can see implementation process. So for the innovation domain, the innovation is the thing to be implemented. So that might be your practice, your program, your policy, the pill, the procedure, or that pathway that you're hoping to get into practice. And the authors really highlight that it's so important to distinguish the innovation and the core components of that innovation, that thing that continues when implementation is complete, to really distinguish that from the implementation process and the strategies that are being used to implement that innovation, which can be a little bit tricky, particularly when you have complex interventions in which there may perhaps be implementation strategies baked in. So really being clear, what are the core components? Within each domain of the CFER, there's different constructs to consider. And to flag a few equity-focused ones here, we can highlight innovation adaptability, so the degree to which that innovation can be modified, tailored, or defined to fit local context and local needs. And another you might consider is innovation costs. So are the purchase and operating costs affordable? The outer setting domain. So this is the setting in which the inner setting exists. So it might be the hospital system, school district, state. There may be multiple outer setting and or multiple levels within the outer setting. So community, system, state. Some constructs here that are especially relevant for equity include local attitudes. So the degree to which sociocultural values and beliefs encourage the outer setting to support implementation and or delivery of the innovation, considering policies and laws, and of course, financing. And then the inner setting domain, this is the setting in which the innovation is being implemented. So hospital, school, city. There may also kind of in parallel be multiple inner settings and or multiple levels within the inner setting. So I think about the nursing unit that I might work on, or the classroom or the team. There are lots and lots of constructs within this particular domain, and not showing them all here, but highlighting physical infrastructure and culture as being particularly equity oriented. And so for the sake of time, we'll skip over individuals involved in process domains, but happy to chat more online. Some key points are here that you might consider combining health equity theories. So for example, critical race theory with CFER that provides a lens for all facets of implementation. I have a really nice paper I can share that's focused on school-based implementation. That's fantastic and a nice example of this. We're also really encouraged within the updated CFER to think about how to expand our focus beyond individual level determinants and recognize the role of systemic or structural forces in driving outcomes. So just to briefly point you to a couple extra resources, I love the additional files that come. Additional file 6 here actually has definitions of all the constructs, which you could consider using to develop interview guides, code books, structuring logic models. And then the CFER Outcomes Addendums paper provides some more conceptual distinctions between different outcomes used in implementation research. So we'll transition over to the Health Equity Implementation Framework, which was developed by Eva Woodward and colleagues in 2019, the same year that EQUR came out. It's also a determinant framework and aims to address healthcare disparity implementation challenges and address determinants that are related to health equity. The authors argue that while theories that account for individual and environmental factors contributing to health disparities have been applied to health services research, these haven't included implementation factors. And within implementation research, there's a large variety, a large gamut of existing implementation frameworks, and some have the capacity to capture certain health equity related determinants, as we saw when we looked very quickly at CFER. But the authors here make the case that if you don't look, you might not find, and that equity might not be promoted even if implementation on the surface looks to be successful. The Health Equity Implementation Framework combines the IPARIS and the Healthcare Disparities Frameworks. The IPARIS framework explains 3 levels of implementation elements, one being context, such as system-level mandates that might overwhelm staff that are needing to be involved in implementation. Another is recipients, such as, for example, providers that might have special expertise. And then also characteristics of the innovation, as we heard about in CFER, such as negative side effects of a treatment. The Healthcare Disparities Framework explains factors underlying differences in healthcare for disadvantaged populations. And so these factors might include patients, such as beliefs about treatment, providers, such as time demands on the provider, the clinical counter, which includes that patient-provider interaction and all of the communication that happens during that visit, and the healthcare system. So hospitals' commitment to reducing disparities or its culture around quality improvement. So you can put these together, and the health equity implementation framework was born. Much of this may look familiar. You've got your innovation or the thing. Recipients are individuals who influence implementation and those who are affected by its outcomes, both at the individual and collective team levels. So in healthcare settings, recipients are typically grouped into providers and other staff, and then patients and caregivers. And then zooming out to context, which we can think about at micro level, including local intercontext, so specific hospital unit or clinic, meso level, including the organization, hospital medical center, and then macro level of outer context, including wider system, healthcare-wise, and effect that this has on other domains. The authors specifically highlight 3 key domains here that are particularly relevant for equity. The first is culturally relevant factors. So these are characteristics unique to a group of people that are involved in the implementation effort. So patients, staff, providers, based on their experiences. So it might be health beliefs, preferences, values, health literacy, implicit bias, trust, as all important factors to consider. For clinical encounter, this is the interaction that occurs between patients and providers in the appointment or the exam room, where there's decisions being made and treatments being delivered, cares being provided. And there's so many different behaviors and perceptions during that clinical encounter that can impact whether an innovation is offered and accepted. And for me as a nurse, I find this as a particularly compelling domain because it's a setting where power dynamics are so prominent. And then last is social context. So physical structures, economies, sociopolitical forces, racism, classism, transphobia, the context within which patients, providers, and other recipients are living and just attempting to be healthy and deliver healthcare. I mean, these are the forces we're feeling so acutely right now. And it's so important to consider the impact of upstream governance on our downstream outcomes, like what unfolds or doesn't unfold in the exam room. And so this framework really emphasizes that potential influence of social forces on every determinant throughout implementation. And so very briefly pointing you to a few resources here. There's also an additional file in a second follow-up paper to the original Health Equity Implementation Framework paper that's got some interview guide examples, code book templates, and suggested quantitative measures for those of you that are doing mixed methods work. So lots of nice content there. And so last up, we'll just touch base on the REAIM extension. So REAIM's widely used evaluation framework that aims to inform intervention and implementation, design, planning, and evaluation. This updated version integrates recent conceptualizations of sustainability with a focus on addressing dynamic context and promoting health equity. It very explicitly highlights equity and cost as fundamental driving forces that have to be considered across REAIM dimensions to enhance sustainability. So the first domain here is reach, or the number, proportion, and representativeness of individuals who participate in an evidence-based intervention. And so through an equity lens, some questions you might ask yourself are all populations equitably reached by the EBI? Who is not reached and why, and how can we better reach them? Effectiveness is the impact of an intervention on important health outcomes or behaviors. So this includes quality of life, and I think a really interesting area that we haven't looked enough at is unintended negative consequences as well. And so you might ask, are the health impacts experienced equitable across all groups? Are certain groups having higher negative effects, or are they having higher burdens? Are we even looking for those burdens? And does effectiveness continue over time, or do we see drop-offs? Adoption is the number, proportion, and representativeness of settings and staff who deliver the program. And so you can think about, were low resource settings able to adopt the EBI to the same extent as higher resource settings? And what adaptations might be needed to facilitate adoption? Implementation domain looks across multiple staff and setting levels, and the indicators include consistent and continued delivery of the EBI as intended, which gets at fidelity, as well as adaptations made and the costs of those adaptations. And so thinking about what settings or staff successfully delivered the EBI and which didn't, and do all have the capacity and resources to do this on an ongoing basis? And last is the big one here, maintenance sustainability, of which there's kind of four kind of key parts to think about. Indicators include the extent to which, one, the health impact or benefits, outcomes, and behaviors continue for patients, the extent to which program activities or core functions of that EBI continue to be delivered at the staff or setting level with fidelity, as well as the evolvability of the evidence-based intervention over time, which this is what includes adaptations. The extent to which community and organizational capacity and infrastructure to deliver the EBI. And the last, and I think this is often what we're really looking towards or hoping to get to, is institutionalization, or the extent to which that EBI just becomes part of routine organizational practices or policies. And so through an equity lens, you might be thinking about here which settings and populations continue to be reached long-term. And within this framework, we think 1 year plus by the EBI and continue to receive those benefits over time, and really getting at why or why not. And so as we wrap up, and importantly, we don't have to think about evaluation as static or an end of a research product activity. The implementation of interventions in dynamic context often requires an ongoing monitoring of intervention to context alignment, which is really important because when this process is absent, an intervention can start with really high potential for impact, but then may gradually lose this potential at multiple key steps throughout the research process due to loss of clinical sites, study participants, implementation failures, or challenges or difficulties with sustainment. And so I have a QR code here. This new paper from Perez, Joles, and colleagues presents the REAIMS outcomes cascade to demonstrate how use of iterative implementation action cycles can be used. And this can help us understand those voltage drops that may occur with response to equity in an implementation experience. So for example, if reach is low or there's no adoption of an EBI, it can't even be effective or sustained. And so we can see here within this cascade how REAIM outcomes are interdependent and intertwined. And so zooming out, kind of tying this all together, I really like this visual from Moisey and colleagues who identify key steps for implementation. You might think about this as a roadmap, kind of depending on your lens. But you can think about from the beginning, selecting or adapting an evidence-based intervention, to identifying barriers and facilitators to implementation, to selecting, using, adapting implementation strategies, and evaluating the implementation success. We can see how different types of frameworks, from determinant to evaluation to process, can help us along all these steps throughout the cycle of implementation research. So I'm going to transition and hand it over to Stephen, who's going to take us from the conceptual to the more applied and share some examples from his scholarship.
Awesome. Thank you so much, Katie. Katie did the heavy lifting here. There is so much to learn about those theories, models, and frameworks that yeah, I just feel like you could spend years studying these, and you would probably still have just a cursory understanding of the whole landscape. So when it comes to my part, what I'm going to present to you all is kind of how I have navigated this pretty complex landscape of theories, models, and frameworks as an early stage investigator who kind of came to implementation science as like a tool that I realized was needed to advance the research in the area that I study, which is around HIV prevention and sexual health. So I'm going to show you some examples. But before I do that, I want to give you a little bit of kind of context of what I study. And like I said, I really study HIV prevention. And oftentimes I present to audiences that are all HIV researchers. And I know this is probably not one of those audiences. So I get the rare opportunity to actually zoom out and be like, wait, why are we using implementation science to study HIV prevention? I think it's actually a really good illustrative example of where implementation science is like the perfect research tool for a specific public health problem. So, for those of you who are not as familiar with the HIV epidemic, I want to give you a little bit of background about kind of where we've come from and where we're going. Like to show this graph on the left, which shows HIV/AIDS related mortality in the kind of late 80s, 90s, and 2000s. And what this shows us, this is a time in the epidemic where we can see both the time when the epidemic was getting way, way worse. This is in the 80s and into the 90s. And then a time when a key medical innovation was invented, which is highly active antiretroviral therapy, which is the combination medication that treats HIV, and how that completely changed HIV treatment going forward is extremely effective. It brings viral loads way down. People's immune systems recover. They live basically healthy lives for the rest of their lives because of this medication. Huge innovation. So in our graph here, you see that happen so clearly here in 1995 and 1996. But I want you to look at this from an equity lens and see how did this affect different racial groups in the United States. The kind of reddish brown line on top is the black individuals in the United States, and the greenish line on the bottom is white individuals. And what we see is that this incredible medical innovation brought mortality rates down extremely low for white individuals. And while it dropped mortality rates for Black individuals, they remained extremely disparately impacted and with high mortality, such that into the year 2011, mortality rates in the Black community were still higher than what they were for the white community at the peak of the epidemic. So what this shows us is that medical innovations can be extremely impactful, but the benefits of those medical innovations, unfortunately, in our society, oftentimes are not equally distributed across our society. And so that means that from an equity lens, these medical innovations can actually really make no progress on equity, or in some cases, uh, kind of backtrack how we're doing with our equity metrics. Okay, so that was the 90s. And you see my graph here on the left ends in 2011. The graph on the right starts in 2012. And that's because something really big happened in 2012 in HIV prevention, and that was the development of pre-exposure prophylaxis against HIV, or PrEP. So PrEP is a pill that is taken to prevent HIV. It's typically taken as a once-a-day pill, although recently in the last couple of years, they've formulated a long-acting injectable version of PrEP. The great thing about PrEP is that it is highly effective at preventing HIV, over 99% effective when taken as prescribed. It's very safe, and it's generally very well tolerated. So it's like a very great pharmaceutical approach to preventing HIV. What's the catch? The catch is that in order to get PrEP, you need some baseline lab tests. You need to get a prescription from a doctor, and you need to occasionally follow up to kind of keep an eye on some of those lab levels, which means that in order to get PrEP, you need great access to health services, which, as we know, is not the case for many people in our country and globally as well. And specifically, there are enormous disparities in who has access to health resources, specifically racial disparities. So then we see, okay, we have PrEP, another incredible medical innovation. how did it roll out, and who got access to PrEP. And you can see that in the last 10 or 15 years, white populations have had really great improving access to PrEP, while Black populations have had very slow improvements in access to PrEP with a huge disparate gap. So, what does this tell us? This tells us that we need to do something to understand we have an intervention that works so well. Like I said, this is 99% effective. This is a pill that really, really works, but it is not getting to the people who need it. So this is why implementation science is critical for HIV prevention, and it's one of the key tools we need to use to understand how to get PrEP to the folks who really need it. Okay. With that background, now what I'm going to do is I'm going to give you just a quick cursory overview of some of the work that I've done in the past 4 or 5 years that has, and you'll see this, it has kind of slowly incorporated implementation science into it. It starts with the kind of motivation that I just showed you. It's like we have huge inequities in HIV. We need to do something to address this. It is required if we hope to make a dent in the epidemic and eventually end it. So, okay, we're going to start to use implementation science methods, and we'll see how some of those frameworks fit into that. So I'm going to start with this project, which was one of the first ones that I ever did that kind of had some implementation science flavor. And this was a partnership with the Philadelphia Department of Public Health, which you'll see is a theme in my research. But we worked with the health department to look at community-based organizations that they were funding to provide HIV prevention services. And we wanted to talk with them about how they were providing culturally relevant services for LGBTQ populations. This was a wide range of organizations, and we wanted to understand what tools did they have for providing really relevant and appropriate services for LGBTQ communities here in Philadelphia. And so what we decided to do, the way we decided to kind of assess this, is that we wanted to visit each site and really try to kind of compile a comprehensive inventory of the tools and resources that they had around delivering this kind of culturally competent care. So we met with leaders at each site and conducted these kind of in-person walkthroughs. Is kind of what I mean. We sat at tables and talked for a long time, but we also walked through their organization and kind of talk to people and say, oh, this person works over there, and here's the kind of posters and displays that we have, and so we could see a lot of the physical environment as well. Something I'm going to highlight here is we chose not to record these conversations. Rather than keeping an audio recorder running the whole time. It was myself and sometimes a research assistant with me. We were just taking very detailed notes while we talked. And the idea was that we were hoping that this would really promote more candid conversations, because this is a somewhat uh, a somewhat sensitive topic in that it was kind of about like, ooh, how well is your organization serving all of the communities in Philadelphia? So we wanted to make sure people were really comfortable and didn't feel like they were being audited, which they really weren't. The point of this was actually to return feedback directly to the organizations so that they could really improve their services or really build on what they're doing well already. So if we kick it to the next slide, um, I'm going to kind of talk about okay, how did we incorporate implementation science to this? This is an example of where implementation science was really not built into the study design, but it was something that we realized kind of post hoc would be a helpful framework for understanding what is the context in each of these settings that either made it easy to implement culturally relevant services or presented a lot of barriers to providing these services. So we did use that CFIR framework in our analysis. Remember that CFIR framework is a determinant framework, helps us understand the environment or the context that either helps or hinders implementation. And we did something called rapid analysis or using rapid analytic procedures. This is a set of methods that the idea is it can speed up the time from collecting data to having results. And it's really targeted to situations like this where you want to return your findings to the stakeholders like really quickly. Like we met with these folks and the idea was like, we would like to give you something back very quickly, and so that you can use it in your kind of development and the way you make decisions going forward. So we don't have time to really talk about that right now, but I just want to pin that. Ooh, rapid qualitative analysis, potentially a very helpful tool. If we switch to the next slide, I've got some kind of lessons learned from this early project. And the big one was that CFR was really helpful in organizing our analysis. It kind of helped us think about the different buckets that we could place the barriers and facilitators that we talked about into. But in hindsight, it would have been much more helpful had we really built our study design with some implementation frameworks in mind. It could have really helped us guide our interviews in a little bit different way, kind of to get at specific implementation barriers and facilitators. So lessons learned, right? There's also limitations to not recording interviews. We were limited to analyzing the notes that we took, which were sufficient to kind of draw the conclusions that we needed to, but it was not that really in-depth, rich data that we could continue to analyze. And then the last point here is that this was never really meant to be a uh, like a scaled up research project. It was like part of the formative work for a bigger project. Um, but we ended up writing a paper about it. So you never know where a manuscript is lurking. And so that's another little tip that I have for early stage investigators. Don't discount all the work that you did, even if it wasn't really originally kind of meant to be generalizable science. There's oftentimes a method in there that can be described. Okay, let's go forward because I'm using way more time than I'm supposed to. I'm showing you another example. It's another partnership with the health department. This one, implementation science was baked in from the beginning. I learned my lesson from the previous project. I said, so the aim of this was to work with the health department to evaluate. They had four sexual wellness clinics they were rolling out with this very specific goal of providing low barrier prep services, meaning like we are trying to eliminate anything that might get in the way of someone getting prep. If you walk into this clinic, we're going to make it as easy and fast as possible for you to walk out with a prep prescription. It's the health department's idea, sounds great. I tag in and say, let me help you evaluate some elements of the actual implementation of this model. And so we can see what worked well, what didn't work. Maybe we can learn about which pieces should be scaled, which pieces should be refined, and which pieces maybe other jurisdictions around the country can learn from and implement in their cities and counties. So a couple of the pieces here, we did focus groups where we did a process mapping activity, which helped us really understand what the clinical workflow at each clinic was. And I'm going to show you an example of that in just a second so you can kind of see. But that process of kind of drawing out the work that each clinic does was really helpful in stimulating the kind of implementation focused conversations that we had next. And so that next piece was I had one-on-one interviews with the staff. Again, this is all with staff working in these clinics. It's kind of to Katie's point before, especially when we're thinking about determinants, it oftentimes makes most sense to talk about the people who have the power to actually influence the environment and the determinants. And so these are the folks working in this clinic, the folks who actually might be able to make changes. So when he talked one-on-one with people, we wanted to ask them about what did they see as the barriers and facilitators to providing these really low threshold services, and what were the strategies that they used? Like what made this fly? And so that we were hoping that we could kind of identify key strategies that could be plugged in other settings. So let's look at the next slide, which is just a peek at what these process maps might look like. This is a snippet from one of them. And you can see it really is kind of a flow chart that is meant to map out another way to say it is it's a client journey map in another way. And what it shows is like when someone walks into your clinic, what happens to them? Who do they interact with? What are all the things they do? How do they get from walking in the door to, in our case, leaving with a prep prescription? And we filled out everything that happens in between. Let's pop to the next slide because I'll show you just a quick taste of some of the results from this study. Again, one of the things we talked about was implementation determinants. So from our conversations with providers, we saw that there were important determinants in the inner setting, like the organizational culture, being affirming and welcoming for all. That really made it easy to provide these low barrier services. It was addressing kind of issues around stigma and inclusion. And they said that the degree to which they could expand their hours, that is how they were able to actually expand services to a wider population. And they said that's something that has to happen in the inner setting. They talked about the outer setting, about how social needs like housing and food ended up really shaping people's access to these services, and how actually transportation and scheduling were often barriers. Clinics, they tried to expand hours, but at the end of the day, there's only staff to keep these places open for so many hours during the day. And we know it's hard for folks who are working, working full time, working two jobs, to be able to schedule a medical appointment like this. And then we also saw some determinants around the process, around the workflow, how adaptations happened, and places where efficiencies could be built in by streamlining the workflow. Let's look next at the implementation strategies that we talked about. Here, I get to invoke the name of another implementation science. It's not a framework, but it's kind of an implementation science tool that is really widely used called the ERIC Compendium. What this is it's like a consolidated list of key implementation strategies that have been identified across studies over the past, decades in really different contexts. And they say, okay, of course, we're implementing innovations in healthcare contexts all over the place. Eric got together a bunch of leaders and they narrowed it down to 73, the short list of 73 unique strategies that can work kind of across context. And so what we did with our project is we had in-depth conversations with the staff and providers at these sites, and we said, what works? Like, what are the strategies that are really expanding access to PrEP? And they listed them out. They said, we need to do community outreach. We need to build partnerships with other institutions. We need to provide a one-stop shop so that we are not just offering sexual health services, but we're offering food and clothing and referrals to housing services and mental health. Said that is what makes it worth people's while to come in, because all of the different services they need are right here. So each of these strategies can actually be pretty cleanly mapped to one of those ERIC strategies. So I've kind of got them listed in italics below. And this showcases, this is like really the point of ERIC. It lets someone who is maybe not familiar with this kind of sexual health clinic context, maybe not familiar with HIV prevention, to translate and say, look, changing the service site is actually was really helpful in this context. And I've seen that helpful in these different contexts. And we can start to understand how to plug in these different strategies where needed. Let's keep pushing forward. And I'm going to breeze through this last one. This is a current evaluation that we're doing again with the city of Philadelphia, the Department of Public Health, around their teleprep program. Okay, so this is a program that is a virtual way to access PrEP services. And the idea being that it can help to alleviate some of those transportation and scheduling related barriers just by making it super easy and convenient to access PrEP. Okay, amazing idea. We wanted to evaluate it from an implementation science perspective. So if we go to the next slide, you'll see our familiar CFR framework again. This was, again, interviews with staff and stakeholders where we asked them, what about your environment either makes this go or gets in the way? And we learned a lot. We learned a lot about, kind of what were the key influences for the specific modality of telehealth for PrEP. We saw that the convenience and flexibility of the online format was really a beneficial piece of it. But they said that online marketing was potentially excluding folks. So this is a totally online program, which also meant that like all of the advertising was online, and that they realized that that was actually kind of limiting the group of people who might have access. So it started conversations. I'm going to skip us to the next slide. Oh, look, we get to see an example of an outcomes framework. So we use the Proctor framework for outcomes. And we really wanted to answer that question of, was this model being implemented successfully? Okay. And so what does success look like? And so some of the things we measured was acceptability. Okay. So we actually did surveys with the users of this program. We said, is this program working for you? Okay, is it kind of meeting your needs? We found high acceptability. We looked at appropriateness in our interviews with staff, saying, does this fit in your clinical setting? This was done in a clinic that was an existing prep clinic. They did in-person prep services, and they shifted and they evolved, and they said, we are going to now incorporate telehealth into our setting. So we talked to them about what that transition was like. Another key outcome that we measured was reach, or sometimes called penetration. And this is the question of, did this program reach the people who needed prep the most? And so we were able to measure program level data to see who it was. First of all, how many people was it reaching? And who was it reaching? And this was, I think, a really interesting finding, and has really actually kind of kickstarted additional work that we're doing together. What we found was that the program reached a lot of people in a fairly short amount of time. Over the course of 2 years, they scheduled appointments with over 600 participants, and they prescribed prep to over 300 of those. So it was especially compared to the scale of their clinic beforehand, this was like a huge, it was absolutely implemented. Like, it definitely happened. It was adopted and implemented. But then the question of reach came up and said, who is accessing teleprep services? And what we found was that Black and Latinx populations were accessing this service at significantly lower rates than white populations. And so that right there, that was a key red flag, because it says this program is not equitably reaching the folks in Philadelphia who are disproportionately impacted by HIV. And it immediately spurred, it spurs refinement, adaptation, and thinking about how to adapt and evolve these implementation strategies. Okay, I'm going to stop there. I think my next slide is just acknowledgments of all of the folks who are involved in all of this work. But I want to save what little time we have left for questions and discussion.
Thank you so much for a fantastic presentation. I see we have a hand up. Do you want to start there, Katie and Stephen?
So me?
Yes.
Okay, great. So this is a really great presentation from both of you, and I think it's extremely important, especially in our current line with so many EBIs or so many interventions are being implemented in from different teams with the implementation science expertise and without implementation science expertise. And there is more and more implementation science integration to the actual implementation process that I see. My question is, for the complex, multifaceted interventions, healthcare interventions like care models, for example, I'm working on geriatric surgery care models, and they are very complex, and equity is extremely important because most of times when we design any multi-component intervention, it goes to the people. It requires a lot of resources and attention, and it goes to the people that have the advantages or highly resourced, well-resourced academic centers. Like, for example, I'm at Harvard that has a lot of resources, but it's not easy to reach all the kind of peripheral, low resource people or settings, which is a huge issue from the equity standpoint. And they are the most vulnerable ones. So, but when it comes to the practicality from like how to put the implementation science equity frameworks into the implementation or pre-implementation process, it requires a lot of work, like each setting adoption or each population, different barriers, different stuff. And as you pointed, like every setting has different things. Every patient population has different barriers, different facilitators. So when it comes to complex patient populations and complex interventions, it's really hard from the scientific standpoint to put those frameworks into your grant that is going to be really reflected either you're going to make your aims very specifically focused on equity, or you just miss all those things, or you just zoom out and look to equity just kind of from a very, very, very big lens without just really paying attention to a lot of details of different populations, different settings. So what do you think about this challenge? And do you have any suggestions?
Ooh.
Katie, we can't hear you.
Oh.
Yeah.
Do you mind, Katie, if I take a crack at it while you? Okay. So yeah, I think this is like, yeah, this is the challenge. It's really hard to use implementation science. There's the temptation when we saw all of those frameworks, we could look at determinants, we could look at strategies, we could look at outcomes. Like
Yeah,
that's 25 different aims, right? So I think
exactly.
the key, I think for me, the like key guiding principle has to be we need to start at the very beginning and we need to say, what is it that we need to learn? Okay. And we maybe need all of those things at some point, but if we can take it stepwise and say, like, for instance, with the teleprep program, that program was already designed, it was already happening. The key question was there's a couple key questions, but one of them was, is it reaching the people who need it the most? And so we actually could then narrow down and say we actually need to ask a specific question about equitable reach of this program, and that can become one of the aims. And then, okay, yeah, we need to learn a little bit about determinants. So we can put that in context. Okay, there's another aim. Oh, and then we also had a question about kind of, is the efficacy of this what we expected in this context? So okay, so the aims start blowing up a little bit, but I think it comes back to really deciding eh, which of these pieces of these interconnected models is like the critical piece that you need to look at in your context, and then get the other distractions away because you can't incorporate it all into one study.
Yeah, great comment. I really like it. And I think it's kind of like a responsibility for us to like guide how to really start and how to just, make it feasible to use it for especially really complex uh, interventions, because it's somewhat easier when it comes to very clear intervention, very specific patient population. And even it's challenging for those as well. So um,
Yeah, thank you for your comments. I see that we're at time, so unfortunately, we don't have time to take additional questions. There was a question about whether you would be able to share the slides or would be willing to do that. We'd be happy to help circulate them if that's okay with you all. Awesome. Great. Well, thank you so much. I really appreciate you making the time, Katie and Stephen, to present to us today. I think we all learned a lot. This was a really terrific amount of information organized really effectively in a short amount of time. So thank you so much. And for those who missed parts of the talk, we'll post the recording on the PISCE website so you can catch the pieces you missed and we can circulate those slides. So thank you again for joining us, and thank you again so much, Katie and Stephen.